Gilbert syndrome. Alethea White Turner, do Anna James, do Basics. Description: a benign, inherited syndrome, in which mild, intermittent unconjugated hyperbilirubinemia occurs in the absence of hemolysis or liver dysfunction. Pediatric considerations: rare for the disorder to be diagnosed before puberty. Pregnancy considerations: the relative fasting that may occur with morning sickness can elevate bilirubin level. Epidemiology: predominant age, present from birth but most often presents in the second or third decade of life. Predominant sex, male-female, 2 to 7:1. Prevalence in the United States, 8% of the population, 1 in 3 of those affected are not aware that they have the disorder. Etiology and pathophysiology: indirect hyperbilirubinemia in Gilbert syndrome, GS, results from impaired hepatic bilirubin clearance, 30% of normal, due to decreased levels of the enzyme uridine diphosphoglucuronate glucuronosyl transferase, UDT. Hepatic bilirubin conjugation, glucuronidation, is thus reduced, although this may not be the only defect. Genetics: inherited defects within the promoter region of the gene that encodes the enzyme UDT yields reduced conjugation of bilirubin with glucuronic acid. Once considered as an autosomal dominant condition, GS is now thought to be inherited in an autosomal recessive manner. Risk factors: male gender, family history, particularly first-degree relatives. Commonly associated conditions: GS is part of a spectrum of hereditary disorders that includes types I and II. Crigler-Najjar syndrome, 1. However, bilirubin levels in these cases will be greater than 6 mg/dl. Diagnosis: history: a non-pruritic jaundice can occur in the setting of fasting, dehydration, infection, lack of sleep, physical exertion, or surgery. Other symptoms that may present during an episode of jaundice, including fatigue, are caused by the triggering factor and are not directly a result of GS. Some medications may also trigger episodes of jaundice in patients with GS due to abnormal metabolism. These include drugs that inhibit glucuronil transferase, i.e., gemfibrozil, as well as selective protease inhibitors, i.e., atozanavir and indinavir, 2. There is some evidence that tocilizumab, 3, a monoclonal antibody used to treat rheumatoid arthritis, and ribavirin, an antiviral for hepatitis C treatment, may also induce jaundice, 4. Note: the aforementioned drugs have not been associated with causing liver toxicity in patients with GS. Physical exam: occasional mild jaundice precipitated by the aforementioned triggers, fasting, dehydration, infection, lack of sleep, physical exertion, surgery, and some medications. Exam should be devoid of the stigmata of chronic liver disease. Differential diagnosis: hemolysis, ineffective erythropoiesis, megaloblastic anemias, certain porphyrias, thalassemia major, sideroblastic anemia, severe lead poisoning, congenital dyserythropoietic anemias, cirrhosis, chronic persistent hepatitis, pancreatitis, biliary tract disease. Diagnostic tests and interpretation: initial tests, lab, imaging, bilirubin, elevated but 6 mg/dl, 103 moles/L, and usually, LOV, mg/dl, 51 moles/L, 1, C, virtually all unconjugated, indirect, with conjugated bilirubin within the normal range n/or 20% of the total bilirubin. 2. CBC with peripheral smear is normal. Reticulocyte count, haptoglobin, and lactate dehydrogenase levels are normal. Liver function tests, LFTs, aspartate aminotransferase AST, alanine transaminase ALT, alkaline phosphatase, and gamma-glutamyl transpeptidase GGT, are normal. Direct Coombs test is normal. Up to 60% of patients with GS have a clinically insignificant mild hemolysis that frequently can only be detected with sophisticated red cell survival studies. 1. Drugs that may alter lab results: bilirubin level may be raised by nicotinic acid and some other medications and lowered by phenobarbital. 1. Disorders that may alter lab results: bilirubin levels increase during fasting and may increase during a febrile illness. Follow-up tests and special considerations. GS should be suspected if unconjugated hyperbilirubinemia persists in the absence of hemolysis or other liver dysfunction. A definitive diagnosis may be reported after 3 to 12 months of follow-up if the exam and diagnostic workup is otherwise normal. Diagnostic procedures/other confirmatory testing is often unnecessary. A 48-hour fast is impractical and nonspecific for GS. 2. Provocation testing with rifampin, 5C could be employed if there is significant diagnostic doubt. After 12 hours of fasting, an increase of total bilirubin to greater than 1.9 mg/dl 2 hours after an oral dose of rifampin 900 mg distinguishes patients with GS with a sensitivity of 100% and a specificity of 100%. 5. Genetic testing is available in the form of polymerase chain reaction, PCR, or DNA fragment sequencing for DNA mutations in the UGT1A1 gene. Alert: a liver biopsy is not usually needed to exclude other diagnoses unless concomitant liver disease is present. Treatment: outpatient. Avoid unnecessary testing and procedures. Specific treatment is not necessary. 1. C. Ongoing care. Follow-up recommendations: patient monitoring once GS has been confidently diagnosed. No further monitoring is required. Patient education: reassure patients that GS is benign. Educate patients on common triggers for jaundice. Recommend patients to inform medical providers of their diagnosis. Instruct patients to seek medical help if severe or prolonged jaundice occurs because these may be signs of a separate disease process. Prognosis: GS is benign with an excellent prognosis. Patients with GS are able to serve as donors for right lobe of liver for transplantation. 6b. Preliminary evidence suggests that patients with GS may have protective properties against cardiovascular disease, type 2 diabetes mellitus, some cancers such as Hodgkin lymphoma, and all-cause mortality. 7. Complications: there are no known complications from GS.